All right, 11:02, according to my clock here. The stream of entrants has slowed a bit. I want to thank you, everyone, for joining today. We've had a great turnout for this meeting, and we're excited to present this topic to you today, tackling GLP-1s, understanding their role amidst the hype, in partnership with Align RX. Again, my name is Jim Wachtel. I'm Chief Revenue Officer at Health EZ. I'm joined by Becky Fenrick, who is the Chief Pharmacy Officer for Align RX, and my esteemed colleague, Josh Schreiner, Chief Product Officer at Health EZ. We're going to jump into this, but we're really excited because this is the hottest topic, the miracle drugs that are just storming the benefits landscape and other places, in the media, celebrities, et cetera. And they really are miracle drugs. They're doing a lot of good for people, a lot of great things. But like any great thing, you can't address it in a vacuum. So how does this relate to cost? How does this relate to plan design? How does this relate to supporting your members that need to use these drugs or want to use these drugs? And what are the other things they need to be thinking about? All things that we're really good at here at Health EZ, and we're really looking forward to helping you and your members with. So with that, I'm going to turn it over to our panel, Josh and Becky, and we're going to jump right in. Oh, one more note. I'm sorry. If you have questions, there's a Q&A button at the top of your screen. Please post your questions using the Q&A button, and we will address questions at the end. We only have 30 minutes booked today, so if we don't get to all of your questions, we will follow up and answer them directly if we miss them. And we are also recording this webinar for later viewing for those who want to see it again or anyone who misses it. So again, thank you, and over to our panel.
All right. Well, I want to once again welcome everyone to this webinar today. This is a very interesting and complex situation that we are going to go over today with respect to the use of certain class of medications for the treatment of obesity, but they also have uses in the area of diabetes. So we'll touch on that, some of that as well. But before we get into the slides, I do want to pose a question to the audience. I am really curious about how your organization is covering GLP-1s. Are you paying for the GLP-1s, which are the newer medications in this space, like the Ozempic or the Wegovy? Are you paying for these medications for the treatment of diabetes or the treatment of obesity management, or for both? So if you would like, please enter your responses into the Q&A, and it's something of great interest for us. But on to the topic of the day, which is obesity and the treatment of obesity and the impact on the health benefits that you would provide to enrollees and to members in your organization or in your organization. Obesity is a very complex disease, and it is truly a disease. It's been classified that way by the American Medical Association. American Diabetes Association recognizes it as a disease as well. So it is above and beyond just what you eat versus how much energy you expend in the day. There are behavioral aspects to obesity, and that would include your lifestyle choices, like what you eat, how active you are, and just how you go about your daily living. But there's also hormonal influences, or hormones in the body that impact your metabolism and your appetite regulation. And there are genetic predispositions. There are certain certain aspects of your genome that could be making you more prone to being overweight or having obesity. And then there are also underlying medical conditions that could be contributing to this. On top of that, there are certain comorbidities that go along with diabetes and increased risk for other diseases as well. There are cardiovascular issues such as high blood pressure and stroke. There are cholesterol or high cholesterol issues that go along with obesity as well. Some cancers Diabetes is a big comorbidity as well as sleep apnea and a poor quality of life. So when you consider all of this, it is really, there's a lot going on in an individual who is dealing with obesity or being overweight. And we want to make sure you understand what the opportunities could be for providing through your health benefits coverage for medications to address this. So if we go on to the next slide. So what's been going on with obesity over time? As you can see from this chart that was published by the Centers for Disease Control, that obesity has nearly doubled since the late 1980s. An interesting correlation here is that the rise in the incidence or prevalence of obesity in the US population does correlate, interestingly enough, with the introduction of high fructose corn syrup into the US market. So how we eat and what foods we eat are really could be a driving factor within why we are seeing a rise in the obesity rate. Next slide, please. So what's happening with healthcare costs? This is a chart that is taken from a study by the Kaiser Family Foundation, and they looked at the healthcare costs of from large employers in the U.S. that they looked at the population and identified that individuals who are obese have greater healthcare costs than those individuals who are not obese, and it's to the tune of exceeding 50%, or double, more than twice what an individual without obesity would have for the healthcare costs. So this is impacting, obesity is impacting your healthcare costs and the spend that you have for paying for your health insurance for your employees. Next slide, please. So let's go on and talk about the new drugs, the newest miracle drugs that are being used for the treatment of obesity. These medications, though, were actually introduced. The first one was introduced in 2005. It was introduced into the U.S. market. The name of the product is Byetta, and it was the first one that was approved for the treatment of type 2 diabetes. Subsequently, many more products have been brought onto the market in this class of medications, and their use has expanded. But how do they work? The products that are referred to as GLP-1s mimic a naturally occurring hormone or substance in the body called glucagon-like peptide, which would be the GLP. The GLP-1s do increased insulin release. They slow sugar output from the liver, they delay digestion, and they curb appetite. And because of the combination of these, they are known to, in addition to helping control blood sugar in the diabetic patient, they also result in weight loss. On to the next slide. So the products that are on the market, the GLP-1s that are on the market in the US today are listed on this slide. Many of them are approved for the treatment of diabetes. However, some of them are only approved for the treatment of obesity or being overweight with certain risk factors. Those indicated for the treatment of obesity include Wegovy, Saxenda, and Zepbound. Wegovy also has recently been approved by the Food and Drug Administration. In addition to the weight loss indication, it is also approved for reducing the risk for major cardiovascular events. On to the next slide, please. What I'd like to bring out with this slide is how effective these products are and bring in some of the cost aspects of it. What we show here are the products that are primarily hitting the popularity in the weight loss category, even though Ozempic and Mounjaro are not approved by the FDA for the treatment of weight loss. They do cause weight loss as well. And as you can see here, the effectiveness, or how much weight you will potentially lose, does vary by product. And the information that is presented on the slide is based on the approval studies that were done to get the products onto the market. The list price is would be the wholesale acquisition cost. If you are working with the PBM, sometimes they have additional discounts that would come into effect, and so your actual costs may be less than what are shown here. On to the next slide, please. So one of the questions that we are often posed with is, are these medications safe? As I mentioned before, Byetta has been around, and so this class of medications has been around for nearly 20 years. It came to market in 2005. Other questions that we get are these safe for the treatment of obesity? Well, the first one of these products that was approved for the treatment of obesity came to the market in 2014. So we do have a lot of market experience with respect to these medications, and they are generally considered safe and effective. However, they are not without side effects, and they are not necessarily the easiest medications to take. Some of the common side effects are nausea, diarrhea, abdominal pain, vomiting, and constipation. When you think about the way these products work, they slow down the emptying of the gut. And so there is naturally coming along with it, you do get a lot of the GI side effects that are associated with these products. And they tend to be the more common side effects that you would see. In addition to the common side effects, there are other more serious side effects that can occur. And so anyone taking these medications should be working closely with their physician or other healthcare practitioner to make sure that they are tolerating these medications and that they are not interfering or causing any other health issues associated with this. Next slide, please. When we think about these medications, and contrasting to what we see perhaps with other classes of medication, where we see increased utilization over time because of changing prescribing patterns from the physician, we're seeing other aspects driving utilization. In addition to the traditional direct-to-consumer advertisings that the pharmaceutical manufacturers would be putting out there, you'll see several celebrity testimonials. Many social media influencers are talking about this class of medication, specifically for the treatment of obesity. You're seeing direct-to-consumer promotion for med spa, through med spas and through health and fitness organizations as well. On top of that, the diabetes treatment guidelines have changed in the past couple of years, and we'll go over to in the next slide, or the upcoming slide, some of the changes to the diabetes treatment guidelines that are impacting that utilization as well. And then more recently, the results of the Wegovy study, or the SELECT study for Wegovy, that did show that the cardiovascular risk reduction benefit for individuals, whether or not they had diabetes, were gained with the use of Wegovy. Next slide. So what happened with the treatment guidelines for diabetes? In 2022, or prior to 2022, metformin, which is a relatively inexpensive generic medication, was considered a first-line agent for most type 2 diabetes, most non-insulin dependent diabetes. However, in 2022, the American Diabetes Association updated their treatment guidelines, and now they recommend first-line therapies. Really, the selection of the first-line therapy depends on the comorbidities of the individual patient. So it's a much more personalized approach with respect to what products are considered first-line. And there are certain situations where GLP-1s are definitely the first-line product to be used for the treatment of type 2 diabetes. Specifically, in individuals with atherosclerotic cardiovascular disease, the ADA recommends using GLP-1s that have a proven cardiac benefit. And there are three GLP-1s that have that proven benefit. That would be Ozempic, Trulicity, and Victoza. In addition to the CV risk, cardiovascular risk phenomenon, the ADA also indicates that for individuals who are diabetic and are also obese or have overweight with certain risk factors, that selecting an agent to control the blood sugar that also addresses weight loss is appropriate and should be considered first-line therapy if it's appropriate for the individual patient. So considering this, along with the increased awareness for obesity, we expect that the utilization of GLP-1s will continue to grow for the next several years. Next slide, please. I'm sure a lot of you are thinking, well, how do we pay for these? And does it make sense to pay for these? I've been looking and watching the literature to identify if there are cost effectiveness studies out there for the use of GLP-1s. Right now, in the realm of weight loss, there's a study that I found that was published by Prime Therapeutics, a pharmacy benefit manager in the US, that evaluated the healthcare costs for individually newly taking GLP-1s, whether they had diabetes, or excuse me, without diabetes, or they had obesity, pre-diabetes, or a BMI greater than 30, which would mean that they're obese. So in that study, they did find that within the first year, that total healthcare costs actually went up. So they went up by about $7,700 for each GLP-1 treated member compared to the control group in this study. So at this point in time, whether or not GLP-1s are considered cost-effective for the treatment of weight loss, there's more to come. We can't state that yet. We can't state that they're not, but we really aren't seeing it as far as short-term effectiveness of cost-effectiveness of using these agents for the treatment of weight loss. Other studies, however, that are published with respect to the treatment of diabetes, GLP-1s are cost-effective when compared to long-acting insulin treatments. So this study published in the Diabetes Research and Clinical Practice did show that there was an actual cost savings of about $673 annually when you compared GLP-1s overall cost of the healthcare to long-acting insulins. On to the next slide, please. So the question comes for plan sponsors, is it time to reconsider obesity treatment and cover these agents? Thinking back to one of the earlier slides, the Kaiser Family Foundation did find that individuals who are obese do have higher medical expenses than individuals who are not, more than double the cost for their health coverage. So if you decide to cover the GLP-1s or weight loss treatments in general, here are a couple of things that we do recommend. First of all, implement sound utilization management. Make sure that you have great, strong prior authorization criteria, and that the PBM that you're using is consistently and appropriately administering the utilization management or prior authorization criteria. We also recommend that you have quantity limits in place, which is another utilization management tool. If you are not covering the agents for obesity, you should make sure that you have the prior authorization in place and require that the products only be used for the treatment of diabetes and not for other agents for which they are not approved. You should also consider covering and encourage support such as behavioral changes and lifestyle changes and nutritional changes. and encourage the use of weight loss programs. These agents are very effective at leading to weight loss. However, they're more effective if you also if the individual also changes their lifestyle. On to the next slide. And that's the end of our prepared comments today. What kind of questions do we have out there, Josh?
Let's take a look.
Josh, one thing I would throw out there is that the preponderance of respondents said that they are only covering GLP-1s with a diabetes diagnosis. There were some responses that said they would pay 50% without a diabetes diagnosis. So I think this is a very evolving space as you pull out the questions.
Yeah. So one of the questions was, did the cost go up due to the cost of the medication or due to other medical factors? So I think this is about the slide from the Prime Therapeutics study.
Yeah, when you look at that, most of the cost increase was related to the introduction of the medication cost. So there might have been some increase in other areas, but primarily it was the medication cost.
Let's see. Does Healthy Z have any tools or educational material to help groups promote health and lifestyle changes and education for EEs who are trying to qualify for coverage? So I could certainly take a first stab at that. So we do have a wellness program that works closely with our advocacy team. So we do have a diabetes, prediabetes, hypertension program that focuses on education, medication adherence, coaching. So if you don't have that program turned on, definitely talk to your account manager or sales rep about that program. We've seen some great cost savings for employers, specifically around diabetes and the cost of obesity, who've had that turned on for multiple years. So that is certainly something that we offer to each employer.
Josh, let me add to that one. I think that is a fantastic question because as we alluded at the beginning of this presentation, these are really miracle drugs, but they're just one piece of the pie in terms of helping people lead better lives. And that is the other services that we offer here at Health EZ, which we're doubling down on this year, working with our clients to understand their needs and their strategy around their health plan. And I think of this in terms of the BJ Fogg behavior change model. And that's kind of geeky right there. So most of you are probably familiar with that. But in essence, it says if something is really easy, it makes it easier to change behavior. And if it's really hard, it's really hard to change the behavior. And these drugs, I don't think, Becky, and correct me if I'm wrong, they're not really designed for people to be on for a lifetime. So these are a tool to help make it easy for behavior change. And then once behavior change has kicked in through diet, lifestyle, other resources, our clinicians here are that can help with the coaching and the wellness program and things, they can get off of the drugs eventually. But maybe I'm wrong about the intent of these drugs. I know the industry wants people to stay on them forever, but the is what?
Yeah. Well, that's an interesting question. And they are not necessarily designed for long-term. The initial studies were several years, but not necessarily lifetime utilization. There are some follow-up studies going on with these products for longer-term use while they're being used for obesity. So we'll be interested in seeing what the results of that are. The studies for these agents, when there are some discontinuation studies. So in that situation, when an individual has been on these products in using it for the treatment of obesity, they do tend to gain weight back. So it is important that, like I said earlier, and like you have chimed in, that the lifestyle modification also is a key component and will help individuals who take these agents once they go off them, either because of their benefit runs out, or they experience side effects, or the cost of the product, just staying on it is to be too much. They will probably gain some weight, but it doesn't necessarily mean that they'll gain all their weight back, and they're going to be more successful with the lifestyle modifications at maintaining their weight loss.
All right, we've got time for maybe another one or two. So there's a question asking, are hypertension, high cholesterol, and family history of type 2 diabetes and a BMI greater than 30 enough to get GLP-1s approved? So I'll take the first answer, and then Becky, you can maybe elaborate further. What we are seeing from most employers from a self-funded, level-funded perspective is are not covering GLP-1s for weight loss, meaning it doesn't matter if the criteria would be met. Weight loss, surgery, or medications are not covered by the plan. Now, if an employer does decide that they do want to cover either weight loss or weight loss medications, then yes, you're getting into the clinical criteria to qualify. But I just wanted to level set that very few employers are actually covering them in that fashion today. But Becky, go ahead.
Yep. I mean, one of the, I believe they mentioned diabetes in there. If there's truly if the products are being used for diabetes, most plans are paying for the GLP-1s for diabetes. Many plans do require a trial of metformin, which is still reasonable, especially if the individual doesn't have the cardiovascular risk profile that was specifically cited in the ADA treatment guideline updates. So I just wanted to put that in there as well.
Great, thank you. All righty, one more question. What about broker-specific educational tools so that we can more effectively sell Health Easy as a solution to the health and lifestyle programs related to savings, white paper, true ROI that come from this? We absolutely have case studies. We can do a claims analysis on any specific employer and provide an expected ROI, as well as go over some case studies with employers who have elected to turn on these programs, and we can give you a sense of what type of savings they've achieved over the long term for some of these medical conditions, chronic conditions.
Josh, let me just add one to that too. I think there's some question about various point solutions that we work with to help with these various strategies. And there are a number of point solutions that we work with, and many of you, for the brokers in the audience, you have your own strategies and solutions that you bring. So we have some favorites that we can help you with and things that we've built in-house. But if you've got something that's working well for you and you need a new best-in-class TPA, we're happy to work with you on those too.
Absolutely.
All right, in respect of everyone's time, we have a couple of questions that we didn't get to, but we want to make sure we stay on time here. We will be posting this recording, and any questions that we missed, we will follow up with some answers. And in the meantime, if you have other thoughts or things you would like us to help you with, we would love to hear from you at healthez.com or any of our phone numbers. So thanks for joining us today, and we'll see you for the next webinar in about 2 months.
Awesome. Thanks, everybody.
Thanks.
Bye-bye.
Bye.